Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Yeah. Okay. All right. There's Ann. All right. Welcome, Ann. All right. I'm going to switch up the order a little bit, but just before we go there, the minutes. Any questions or any comments, any changes with the minutes? Okay. Therefore, they will be approved. And I'm going to move the family-centered treatment presentation up into the first position. So I think we're looking for Coral and Kelly to help us with that. Welcome. Hello.
Hello. Good afternoon.
Yes.
I'm Coral Klein, and I'm the Children and Families Division Manager.
And I am Kelly Bell. I am the Assistant Supervisor of Youth Treatment, and I supervise family-centered treatment.
This afternoon we are going to be... Oh, that does not move the slides. Just kidding. Hold on a second. Perfect. There we go. This morning we're going to be talking about family-centered treatment. We're going to tell you what family-centered treatment is. We're going to talk about why we need it here in Washington County and who it serves and what its goals are. We're going to talk about how it's been funded and how it's currently funded and how we hope to fund it, and really the future state of the program and how it's going to interface between multiple programs and multiple departments in Washington County. Why do I keep doing that? Okay, so why did we pursue family-centered treatment? We first started this endeavor back in 2020 when the Children and Families Division had around 12 to 15 kids in residential treatment at any given time, with an average length of stay of about 16 to 18 months. That is a significant cost to the county. Parents do pay a portion of that back through child support, but the county bears all those upfront costs for out-of-home placements. And those out-of-home placements are anywhere from, I would say, $300 to $500 a day, give or take. It's kind of a wide range of rates. And those programs also have limitations. The residential treatment model has limitations where kids are housed somewhere and their family unit is at home. So the kids are receiving those treatment. Parents and family unit may be receiving a small amount of family therapy, but there's really limited family involvement or ability to practice new skills with each other, whether the child is trying to try some new coping skills in the family environment, and the parent's ability to parent them. As you might imagine, we were seeing some poor outcomes post-treatment. Kids were being reintroduced into the home after a period of time in residential treatment. There's continued family discourse. Again, if that environment doesn't change, kids often do not do well when they return home. And we're seeing kids cycle through multiple placements. So we would go through to one residential program. A child may complete that program, go home. Things weren't going well, and a child was removed again from the home and placed in another out-of-home placement, whether it's another residential or another higher level of care. So we started thinking about what we could do different for our kids. And at the same time, the CCS program was building their service array, and we were talking back in 2020 now, so this is quite some time ago. They were building their service array because it wasn't quite robust enough for the complexities of the kids that we were seeing that were rising to the level of being placed outside the home. So in those conversations, myself and Doug and Kelly and Sarah and Julie, we really started to look at how we can integrate our two divisions to really provide a different solution for children and families in Washington County. And that was coupled with the fact that DCF launched this Youth Justice Innovation Grant, which is really looking at kids in the youth justice system, how to match services to needs, how to reduce recidivism, and how to keep kids in their communities. So through that process, we started looking at a number of programs. We looked at, family-centered treatment and family functional treatment. Doug and I had multiple conversations with counties across Wisconsin about what worked best for their kids, what the dollar amount was on the training, what the commitments were, how to do this program to fidelity, and figuring out a way that we could pick a program that we could not only do, but sustain on the long term through funding and reimbursement. So we got to family-centered treatment. And I'm going to continue to pick the wrong button this whole time. So some initial goals, and I would say they were our initial goals, but continue to be our goals for this program. This program started off almost exclusively serving kids in the youth justice system because it was a youth justice grant. So we're really looking at reducing kids entering out of home care, and also supporting families, the post-residential treatment. So those kids that do have to be placed outside the home, when they do come home, how can we wrap around the entire family and put in supports, navigate those struggles, help them reintegrate, and provide those better outcomes. And those are really around family communication, relationship, and quite frankly, giving parents the skills to parent kids with difficult behaviors, and be able to do that together as a family unit. And now I'm going to turn it over to Kelly. And hit the wrong button for the fourth time. There you go.
So I'm going to talk a little bit about what family-centered treatment is and how we do it, and then what it's looked like for us in Washington County. So family-centered treatment, it is evidence-based, and it is in-home treatment. We work with the entire family unit. Although we have an identified client for billing purposes, we really consider the entire family the client. And we allow the family some freedom in identifying who that is. For sure, everybody that lives in the home, but if grandma is often a caregiver, then maybe grandma's looped into treatment. Whoever really has a big part of that. We really don't want to chase behaviors or chase crises or solve like the issue of the week. We want to get at the underlying root causes of the behaviors and really reorganize how the family is structured so that we can reduce those behaviors long term instead of just putting a Band-Aid over it. Throughout FCT, there is also systemic trauma treatment, and you'll see that on the next slide, but we really want to be treating the trauma throughout the entirety of the treatment that is being provided. We do some various stages of assessment, which I'll get into in a little bit as well. So the typical length of treatment for FCT is about 6 to 9 months, and it is 4 to 6 hours of in-home family therapy. So it is a big commitment, but we try to do 2 sessions for 2 hours a week with the entire family. So these are the 4 stages of treatment that FCT goes through. That first phase is getting to know the family, doing assessments, and really identifying what is the cause of the issues. So we're not doing a lot of treatment in that first month. It's a lot of assessment, a lot of rapport building, and gaining trust with all the family members. The second stage is restructuring. That is the meat of FCT. FCT is not a talk therapy model. We do more experiential type therapy. So if a family has difficulty with communication, one of the activities we might do with a family is called a Lego build. So you have one person have the instructions, one person be the runner, and one person be the builder. And you work through with the practitioner, okay, what went wrong? What was really hard? What commitments are you ready to do moving forward over the next week? And maybe dad is like, I just got so frustrated, I shut down. And so over the next week, I am going to voice my frustrations. So things like that. We use different activities to practice different skills so that the family can start shifting those dynamics. Value change is when some of those changes are starting to be seen, and parents are starting to kind of take over in a good way. Maybe parents are leading the activities, What I really like to say is by the time we get to value change, the parents will be calling the practitioner and saying, hey, this happened, this is what I'm going to do about it. Whereas early on, we get calls saying, oh my gosh, this happened, what do I do? I'm freaking out. So we start seeing that shift to parents really taking on that ownership. Generalization, that's probably the last month. That's where we really empower the family that you guys have done this, you've done the work, we've given you the tools, and you've accomplished it. How are we going to maintain this progress? What are we going to do to make sure that things don't backslide or things don't fall? So the 5 pillars of FCT: treating families with dignity and respect, honor the function of the behavior. So we're really looking at, instead of disciplining the behavior, why is the behavior existing, and addressing that concern. We want treatment to be relevant and useful to the family, and we want it to be internalized and ongoing instead of compliance-based. So especially with some of our teenagers that we get here, they do it because they know they have to. Our goal is to really internalize some of the changes with everybody in the family, so it comes second nature instead of I'm doing it because. And then the power of giving and restoring self-worth. A big aspect of FCT is that at the end of treatment, the family will do a give back project, showing them that they are worthy, they have something to give back to the community, and we empower them to do that. All right. So these are the FCT guarantees. This is just kind of identifying what we tell the family when we walk in the door. We are giving direct and honest feedback. We want to receive direct and honest feedback. We take responsibility for our mistakes. Everybody makes mistakes, including clinicians. The parent is the expert in the family, and we are providing them tools to amp up their abilities. We are asking permission before we are doing activities with their children, and we are being transparent. We are gonna, at the end of the activity, say, hey, I felt like that didn't go great today. What do you guys think? And we want honest feedback from families with that. This is just a little map of the places that are offering FCT right now. So it is expanding. It is getting much bigger. And there are several counties in Washington County, in Wisconsin that are implementing FCT. So our measures of success, we do a trauma screener at the beginning, middle, and end of treatment. And that is done by the child, or if they're younger than 11, the parent will do that for the child. This is kind of how we measure how the family is progressing in treatment. The next one is called a family assessment device, or a FAD. With that, it is looking at a questionnaire that everybody in the family completes, again at the beginning, middle, and end. And it spits out a number of where the deficits are, whether it's communication, effective involvement, roles, behavior control, and that is how we identify what we're targeting in treatment, and then we can measure that along the way to see if it's getting better. Through each transition between those 4 phases I showed you, there's also a family report. They fill out a questionnaire every time to indicate what has gone well and what has not. This is our current implementation status. So with the FCT Foundation, they are heavily involved, and we are currently 71% implemented at Washington County. And that is from April of this year. And we currently don't have anything that's not in place. So this is a big accomplishment for us as an agency to come that far in implementation of this evidence-based treatment. And here is some data in graph form that I wanted to provide today. I will add a disclaimer that we recently changed electronic health records with the foundation, so the only data that I have here is for clients that have opened and closed in 2024. That is a very small sample size due to how long treatment is, but it gives you an idea. So this is that trauma screener. As you can see at the beginning of treatment, the numbers are much higher. There is a dip in the middle, and we don't have enough data to fully say yet what that means, but my inclination is that's in the middle of restructuring when there is like super high support, super high treatment with the provider. And although it goes back up, it's much lower than it originally started. So we have laid a positive foundation for the children to be able to work through their trauma and move on to individual therapy to really dig in and process that trauma now that the family dynamic is established. Same thing here. This is skewed to only 2024 kids who have opened and closed. But this is that family assessment device I talked about. These numbers, we see them very high in the beginning. We often actually see them spike mid-treatment because that's when we're really getting a lot of the elephants in the room out. We're really digging into the issues. And then by the end, we see those numbers go down. So that is the common trend. Again, we don't have enough of a sample size to really say for sure quite yet. And then I indicated some treatment success. So this is family report. We had 8 out of 10 in 2024 that successfully completed treatment and remained in the home. And we had 8 out of 10 maintain placement with family of origin. And these are family reports of their satisfaction of FCT and improvement of those area of family functioning, like communication and things like that. So overall, very positive feedback for families that we've served this year. Again, we created more safety in our family during FCT. Much, as you can see, it's a lot of positive feedback. And that out of 7, everybody either agreed or strongly agreed that FCT has improved their family life.
It's my turn, Mike. So great. So thanks to Kelly and Coral for presenting that. So, I get to do the pleasure of talking about the dollars and cents of the program. And so, as Coral indicated at the beginning of the presentation, and what we'll talk about later in today's meeting is that the high driver of the Human Services budget is our out-of-home care budget. And as we've been seeing that exponentially grow, knowing that we're not getting the outcomes that we want with kids and families, we've been talking about what can we do to change that. But to invest money to impact something that's at the deep end of the pool without really knowing 100% if it will impact the deep end of the pool is sort of a hard thing, I think, to ask for and present. And so we had this opportunity to apply for a Youth Justice Innovation Grant to essentially give us the seed money and the time to implement this program and pilot it to see if it was going to start having the success that we hoped that it would be. And also, the big question of would or could it pay for itself, or could we draw down reimbursable dollars to support the program long term? Because it's a different conversation if it doesn't, and we have to come forward and ask for tax levy for that program. So this just shows you what the dollar amount we got for a Youth Justice Innovation Grant. So the first year, we essentially got enough money to pay for the whole program, and then the dollars have reduced every year thereafter. As we've been going through implementation, and when we did our 2024 and 2025 biennium budget, we then did implement some tax levy dollars to cover the cost of the program because we were continuing to determine if this program could be self-sustaining or not. Next slide. So this next slide just sort of details for you the current scenario and what we think could be a future scenario that we're currently analyzing. One of the strategies that the Human Services Department uses in providing services to the community is the use of contracted partners. Contracted partners can be very beneficial because they can help us do work that maybe we can't do, or they can reach the community in a way that we can't. But they also allow us to be more flexible in growing and reducing programs without having to add county employees, especially if we're trying to pilot something or grow something very quickly. So we approached this program with that in mind, that we knew we could rely on one of our contracted partners that we've been working with for a long time, and they would help us to set up this program, and we could utilize the grant funds to pay for that, with the idea that we could project out Medicaid reimbursement in the future. So if you look at the current scenario, we currently have a contracted therapist. That's the cost of their contracted therapist. And then we do have a county therapist or county employee who's a therapist in the program that we put in the budget in 2024. You'll probably ask yourself why that cost is different. And so one of the things that we're seeing with contracted partners is it's starting not to be economically advantageous for us as it used to be 5 to 10 years ago. It used to cost us a lot less to have a contract than it does now, for a number of reasons. Well, everybody's costs are rising. They want to attract and retain staff as well, so they need to pay those staff. You're essentially paying double overhead because you're having, they have their own overhead. And then they have an allowable 5% profit with Medicaid reimbursement. So there's a profit that's in there, as well as they're covering, their overhead covers percentage time of their supervisors and their directors and that type of thing. So that cost of that therapist includes all of those different budget line items. So this year we budgeted that contract with some tax levy and then some grant money, and then we projected out $75,000 of Medicaid reimbursement. And in our analysis of 23 and 24 and the projection for the rest of the year, that therapist revenue will be $150,000. So 2023 and I would say half of 2023 and all of 2024, we've been at a place where they're full case loaded and we're fully billing Medicaid. And so that was a really exciting thing to see, that the Medicaid revenue was being generated to support the program. So right now we're projecting a revenue over of about $75,000. Conversely, for the county therapist, we allocated more tax levy to that position and less Medicaid because we anticipated that the county employee would service the individuals that we could not bill for. So families who don't have Medicaid, and we couldn't bill. But what we're seeing is that is just simply not the case. The numbers are not there of clients or families that we can't bill for. And so our county employees' revenue projection also exceeds what their current cost is. So that right now we're in the state of analysis and trying to determine, A, will it be more cost effective for the county to bring on both of those therapists as county employees, because we also know that we also have a little bit more control and oversight of an employee when they're ours. Our contracted providers are great partners to us, and they work very closely with us, but there is a difference when you have a dotted line supervision and a direct line of supervision to an individual. And if you ask my staff, they ask me every day if we can just have county employees. And so this is the part of the analysis that we're doing. Right now, the numbers say to me that not only will this program pay for itself, but will also save tax levy in the end. And that will help us in our next biennium budget when we're prepping this, planning for the funding of this program. One of the benefits, however, of continuing to keep our partnership is if we want to grow this program, then we can continue to ask our community partner to bring on another staff person and grow the program to sort of do a little bit of that ebb and flow of, well, how many therapists is enough therapists to meet the community need? The caseload's very small because of the intensity, so it's about 5. Is that accurate? And so Right now the staff is saying, I think we're okay, but maybe in a year we might want to add another position. And so for me, that's a good timing, I think, for the biennium budget to sort of figure out if we're going to grow the program, we would do it in that time frame. But right now, we're in the decision making around whether we'll be coming forward to this committee and asking to bring that position in-house as a county position and show you how we're able to fund it. So I'm going to stop there, and then did you want to show your?
So that one, I had another slide, but we had two separate ones.
Oh yeah, that's right.
But I can share a little bit of information. So I had a picture of a family who was one of our first FCT clients, and they graduated probably about a year ago, and they sent their FCT practitioner a picture of them graduating high school. And I actually just got an update yesterday that the same client just got her license. So just a lot of positive feedback. We've had a couple kids at risk of being on the sex offender registry due to things that they did that were not great. But they participated in treatment, and they were able to recover through FCT and some other treatments, and they are doing well as well. We also, one of our therapists, Jan Dretzler-Katz, she was nominated by Sarah Whitty and myself for Practitioner of the Year, and she won that. So at our FCT Foundation conference, which was all those states you saw, everybody was there. Out of all of those people, our therapist got awarded that, which was a really cool thing, and we're really proud of her for that.
Did she get awarded based on a case study example, or?
No, it was based on nominations. So
Okay.
supervisors could nominate whoever they felt was appropriate for it. And then the foundation had a committee that chose, based on the nominations, who was the winner, and she was awarded that.
Excellent. Great. I have a one question. It was about the 71% implemented.
Yes.
Slide 11, I think it was. Can you expand on that? I'm not following. You made it seem positive.
Yes.
That's a good number. And so I guess I need some help understanding that.
Sure, of course. So with implementation with the foundation, it is meant to be like a 3-4 year process. It is not meant to be quick. And they have these different implementation drivers that twice a year we go through with our consultant with the foundation and identify what is in progress, what is implemented, and what is yet to be done. So the feedback we've gotten from our consultant is that we have moved from intermediate implementation, to emergent implementation, which means I would anticipate by next year when we do this again, we will be fully implemented, is the plan. Emergent is right before fully implemented. So we are right where we're supposed to be, if not ahead of the game.
Excellent. Thank you for clarifying.
Yeah, absolutely.
And if I could add to that as well, the intensity of training in this program is very significant. And the initial therapists went through training with the foundation. But part of the long-term sustainability is now Kelly is a train the trainer, so that we can have that expertise in-house and we don't have to continue to pay the foundation for their training. And so that is part of the sustainability of that. And I think the other point of analysis for us of having, in-house county employees is that we can also then have them become train the trainers as well.
Excellent. Any questions, comments, thoughts?
I do.
Oh, okay.
Let
Supervisor
Mr. Galitz go
Okay,
first.
thanks.
Thank you, Chair Schultes. So the treatment success, how does that compare? That's in-house, right? That's our 3 years running now.
Yes.
How's that?
3 years, but the data I have here is only for 2024 because of the change in EHRs.
Got it. So the lifetime FCT with 13 success you get, and sample size is 10 for 2024. So what's then lifetime FCT of 13?
Yes, gotcha. So the lifetime that we have calculated is 13 successfully graduated families. Now, keep in mind, that first year, we probably graduated maybe 1 or 2 clients. The second year, it slowly grew from there. So the data, and we just implemented this new system probably in the spring, and I don't know that all this, we're still working out kinks.
Okay.
So based on my calculations, not the system's calculations, the lifetime of FCT, we've graduated 13 clients successfully, which is a 65% completion rate. The graphs look really pretty, which is great, but I don't know that the data is quite up to par yet because of those kinks.
I mean, that's good to know because we're limited to just 2024 and it's a growing process, but presumably that could be extrapolated, that success would continue at a 80% or higher clip. Is that the expectation?
Yes, that is the hope. That is the hope that we're going to keep bulking up our practitioners, keep bulking up our skills in our program to get to a place where we're more effective. It's some of the skills that you do in FCT, you do it once for a family. So to become an expert in that skill with a family, it takes a while because you're only doing it one time for every family, and then you get another family 3-4 months down the road. So as we continue to get more efficient, I think our numbers will continue to grow.
Different scenario, different solutions, et cetera.
Exactly.
How does that data that you showed here for 2024 success rate compared to out-of-home services, which you started the presentation off with?
I don't know if you have that information.
Can you just clarify your question?
So you're saying the treatment success here is based on 2024, and this is in-home treatment, right?
Right.
At the beginning of the presentation, you had mentioned we previously had out-of-home services. So I'm just curious, how does the success rate of in-home services compare to out-of-home services?
So if you're wanting to connect it to like out-of-home
I
care.
mean, because you're
Yeah.
providing
Yeah,
counseling and
I'm not sure it's
treatment
that-
for individuals, right?
Yeah,
Whether
I'm
it be
not-
in-house or out-of-house.
I'm not sure it can be that cleanly compared. All I would say, we've had how many of my kids, because they're almost all my kids, right? So
Yeah, I mean, over half are
Yeah.
directly yours or headed to you in the process. I think the tricky part with that question is it's dependent on that out-of-home placement measure of success. So every placement, residential, hospital, they have different measures of success, so we can't totally, compare it. But I think internally we can, at some point, Coral and I have talked about getting numbers of
Yeah.
how many times did they re-enter treatment without FCT versus how many maintained at home with FCT.
and also those that completed, what's the post-discharge or post-completion of FCT, what was next for them? Did they go into additional placement or not?
So I'm just trying to wrap my head around, I mean, the altruistic and the value to the Washington County and residents is that this treatment is successful, right? So our residents are receiving the care that they need, and it may be at a better rate of success than if they're not in a home. And all the other factors you talked about, the family learns from it versus just
The kid.
some child that's
Yeah.
off over here
Yeah.
versus now they're in that family setting and they can all learn from it, right? And presumably, they won't repeat behaviors one way or the other. Which kind of leads into the next piece about the sustainability and future part of it is, with 2 staff members projected, how many individuals can be treated reasonably. In a previous presentation, we had a little bit of capacity with staffing, and I'm sure it's going to change from year to year based upon need or demand or qualifications or whatever term you want to call it.
Caseload.
Yeah, and I suspect in some cases, youth will be, I guess, forced to have treatment. Is that a term? I mean, I know we have custodial placement and things like that, but is it all voluntary or is it involuntary treatment? And again, that just goes to the capacity of staff. So if we have 2 today and we think that the program may expand, is that because there's needs that currently can't be served? Or are we seeing an increase in, what was the term I saw here, something about, I don't know, inappropriate behavior or whatever that would require treatment? I'm just trying to get a grasp of how do we project what future needs would be, because when you look at funding, creating a biennial budget, what do you base it on? Are you base it on past historic trends of clients served, or what might be happening in the community, or I'm just...
Yeah, we kind of look at past historical trends, what number of kids are currently placed outside the home that may meet, like maybe the target audience for this type of program. And right now, I would say the kids, we only have 8 kids and outside the home in residential treatment. That's not all residential. But not all of them may be appropriate for this program. And even though we court order mental health services all the time, whether it's on a juvenile order or a parental order through Child Protective Services, this is a really big commitment. So parents still have to have amounts of buy-in with, was it six hours a week? That's
4 to 6 hours a week.
And not every family, we've referred to lots of families who have said thank you, but no thank you. This is too much for us, and we've then had to steer them into another type of program.
And I will say to answer your question about future growth, now that FCT's kind of gotten out there, I am getting a lot of referrals from like CCS families, from CPS, which wasn't originally in that cohort that we were looking at, as well as schools. And these are kids that aren't in the YJ system, but some of them have a lot of police contact or have gotten a lot of tickets or are at high risk. We have a lot of families right now where they would be with Coral's group if parents called the police, but parents don't. They just deal with it and allow the house to get destroyed or get hurt because of it, because they don't want their kid in the system. So we are identifying some of those preventative families in hopes that they don't make it to Coral's team.
And that, to Kelly's point, that was always one of the goals of this, implementing this program, was, or so that families can come through Kelly's door and get these services voluntarily to do this preventative work, so they don't have to enter the system, which would then, have obviously a positive effect on the other things that I talked about, out-of-home care dollars and all of those things. So we would just be diverting those families who might otherwise come to us without ample resources to change their family's situation and dynamic.
Sure. So just one last question regarding Julie and the funding. So it's anticipated that T19, I'm assuming, equates to Medicaid?
That's correct, yes.
That we would get as much reimbursement as we could, but what if there's a shortfall? You said that not all families qualify. So is there a pool of funds that have been allocated so that could offset that, or are families charged, but you said not at the full 100% of the cost? So I'm just trying to understand if there is a shortfall somewhere there, how is that accounted for?
Yeah, so typically, and that is one of the reasons that we do contracts with outside vendors, because we do fee for service, and whatever they bill, they get, and the hiring and staffing is their responsibility. When we do our budget for any of our case managers that bill CCS, we do a projection based on productivity expectations, but I would never budget this way where I would say I'm going to pay for somebody 100%, because you can never guarantee 100%, because the county is responsible for servicing all individuals regardless of ability of insurance. And so when we do budgeting for staff, there's always a sort of a blended or braided funding strategy to it. So I might take my tax levy that I'm, allocated, and then I divide it, amongst some of the staffing costs, and then I plug in what the Medicaid projection is. And so that way we're never reliant on 100% Medicaid because we know that we have the tax levy there. But I think that strategy has also been one of the reasons why our budget has been successful, because we have done a really great job in drawing down the revenue from insurance and Medicaid that's available. And so, I mean, in my tenure here, we've always had a positive budget at the end of the year and actually been able to send some money back to the general fund. And so that's typically the strategy that I take, but I'm always also looking at, if we have the productivity measures and expectations there, could this program fund itself? And so as I look at this program now, it can fund itself, but I would never totally erase all the tax levy that's allocated to those positions, just because we also want to make sure that we're servicing individuals that don't have insurance. And then I think as we start seeing the landscape of this program change and who's being referred to the program, that might also change the insurance capabilities, which we have to analyze as well. But one of the things that gets even more complicated, and the team actually has more expertise in this than I do, is mental health is a diagnosis that does make families who have higher incomes, children eligible for programs like Katie Beckett, which is a Medicaid fundable service.
Yep, so I work really closely with Katie Beckett when I screen kids for CCS. And if they are eligible for Katie Beckett, then we can get them that Medicaid source despite their income.
Thank you.
Chair Schleif?
Thank you, Madam Chairman. My questions were pretty much along the same lines as Supervisor Gallett's about the future and, like, I guess the potential future clients or treatments. But I will say my question's been answered, but kudos to you for this innovative solution. It sounds like it's working, and I hope it continues to be successful. And it's a whole lot cheaper than the out-of-home treatments and more effective the way it sounds. So good. Thank you.
Thank you.
And I'll just kind of hopefully close out the questions unless anyone else has any. With just the Medicaid reimbursements, are they covering 100%? How are they actually? Because having dealt with the Samaritan and that kind of Medicaid reimbursement, this is not the same. And so it sounds like the reimbursements are pretty good.
So it's about productivity, and so I think because this program has such intensity to it, then the productivity is there.
Okay.
And so because they're doing 4 to 6 hours for a family, that is all time that they can bill if that person has the eligible insurance. To be, completely honest, the rate hasn't changed in a very long time. And so as we continue to have staff costs rise, right, and the rate stays the same, I'm not, there could be a point where we're seeing that doesn't cover. But right now, the rate, does far and exceed, if the productivity is there, it far and exceeds then what our costs are. But, that's, our salaries increase, our insurance increases, and, eventually you have that tipping point.
And do we as a county do anything on a sliding fee scale? Or is it Medicaid or not?
We typically do in our outpatient clinic for folks who are uninsured. I think at this point we're still in a pilot phase of this program, and so we've not set up a requirement that families pay. If they don't have insurance, it's still a program that we offer to them.
And we really try to get families into comprehensive community services, CCS, and then those are covered by Medicaid fully. And then that also gives them a step down once FCT ends. They still have a case manager, they still have a team that can slowly reduce services so it's not all there and then one day it's all gone.
Great. Well, thank you. Very comprehensive. Yes, Ann.
Just one question. Is there like a waiting list for people who want to get in the program?
Currently there is. It's about 5. We also have one practitioner that's on medical leave right now, so that's a big contributor to that. So we expect when she gets back, the wait list should go away because of caseload of 5. So.
And I would so I think I mentioned this, but one of the benefits of our contracted provider is their ability to bring on staffing much quicker than we can. So we had brought on a third position, but unfortunately, as Kelly said, she went on medical leave. So right now we're still operating at the original 2.
Sorry, I do have one more. I'm thinking about, this is fairly new to me. I don't know, I didn't know it was covered in the nation as well, and not all states are participating, but there are several that are. And I'm just wondering, is this something that we've done any public service announcements about it, or marketed, so to speak?
Not broadly. Just because we do only have 3 people. So I expect if we were to broadly market that, I would get many, many more referrals very quickly. Sure. But I have slowly started to talk about it. I often go to like West Bend School District and Slinger and do a lot of talks with them about the treatment we offer at Washington County. And this is something I do bring up to them. So I've started small, and which is where additional referrals have come in. But I think if eventually we can be broad, we just don't have the capacity to handle that amount.
Understand.
Yeah. Okay.
Well, thank you very much. It was a great presentation. Appreciate it.
Thank you.
Thank you. All right, we'll go back to the top of our agenda order, and we'll have the administration quarterly report. Lee and Anita. Hello.
Hello there. I'm Anita. I'm the billing supervisor for Human Services. And the initiative I've been working on this year is to enhance accuracy and streamline the billing process to improve efficiency. So the first part of my goal is kind of complete, but I just wanted to kind of recap it. So the goal was to review my existing practices and policies, looking at ways to improve financial performance, reduce costs associated with claims processing, and enhance patient collections. As part of this initiative, I conducted thorough audit of our current billing and collections processes. I analyzed data metrics from our clearinghouse to identify error trends, focusing on preventable errors such as invalid member ID that causes, the claim to be rejected, which reworking, and resubmission, which causes costs. Another area is the patient collections for EOS, and earlier this year, Human Services partnered with Waukesha County for managing our delinquent accounts, and after our former collection agency closed their doors. And we partnered with them in late February, and to date, we've successfully collected over $23,000 in patient collections. And the second part of my goal that isn't completed yet, I'm working on centered around measuring and monitoring the revenue, which actually aligns with one of Doug Bry's goals. Doug and I had a couple of meetings to determine what metrics to focus on, and with obvious long-term goal of revenue growth. Kind of worked perfect what we were talking about. So we're currently focused on productivity, and I report monthly through that data. And I think as HSD continues to grow and there's that continual need for services, it's important that my unit maintains a robust billing process because it's essential to sustain positive revenue flow to HSD. So I'm on track.
Great.
So.
Great. Yeah, very good.
All right. Any questions?
Any questions for Lee?
I did have one that is not intended to get into the details, as that's not the intent of this, but you had mentioned about maybe some billing practices and missed data that causes pushbacks, et cetera. Did you determine if that was in range, excessive, anything to be concerned about, put new practices in play?
Not really anything to be concerned about. It's just, I think we're human, and so we look at something and it gets entered incorrectly in the system. So we just put a couple of extra checks in place to ensure that what's being submitted is being submitted correctly the first time to prevent errors. So to kind of give you an overview, in 2023 we submitted over 40,000 claims for billing, and we brought in over $4 million. And from the metrics off the clearinghouse, we had like a 5% error rate. So we don't have a very big error rate, but those errors cost HSD because we get charged every time we submit a claim. So
That opportunity costs, direct costs, et cetera. Just curious, as we've talked at board meetings and others about AI and improvements in data transfer from one system to another. I know I believe in my tenure, the county has adopted different software applications in other areas that was to improve billing efficiencies, et cetera. So, every time you do data entry, there's an opportunity for an error, to your point. So if that 5% can be reduced to 2.5 and the juice is worth the squeeze, extra time, effort, or a process procedure, well, then you reduce it by 50%. And
we just implemented Avatar, so that's a new EHR. So, and we just did a whole new revamp, and we went live with that in May. So,
okay.
Yeah.
It'll be interesting to see as you look at metrics for 2024 in part and then 2025 in full, how that compares to the 2023. Thank you.
Sure.
Thank you.
And now Lee.
Okay.
Yeah.
I was like, she is not here. Okay.
Hello. I'm Lee Sanderson. I'm the office manager. I wanted to give you a couple updates on my initiatives that I've been working on. One of the ones that I've been spending a lot of time on is improving our billing process for our external providers. So as Julie mentioned in another presentation, we do contract with several external partners that provide services to our clients, and my unit is in charge of processing that billing. So it has been a very clunky process over the years, and we've improved it here and there. And so this initiative that I've been working on was to continue to improve it and also move away from a platform we were using called ShareFile to a new platform that IT prefers us to use is SharePoint. So it's more efficient, it's HIPAA compliant, and it's also very easy to use. So I completed the goal. I've transitioned, I want to say about 30 providers onto SharePoint, and they're all very happy with it. We've gotten a lot of positive feedback from the process that I created. Since that's been completed the end of June, which did meet my target date, I've reached out to some of the supervisors and managers within Human Services that process other types of invoices, and we're transitioning some of that onto SharePoint as well. So it's kind of we're just taking a little step further and maximizing our use of SharePoint. So it's a good system. So that's done. Any questions on that? Okay, the second initiative, it's improved process for reporting Wisconsin Medicaid cost reporting. And what Wisconsin Medicaid cost reporting, we refer to that as WMCR in our department. It's an annual report that we compile, and I handle the external partners. So all the providers that provide services through these partnerships, we have to report the hours of service that they provided to, they provide it, we bill it to Medicaid, and we have to report that to Medicaid. So it all has to balance out. So I have to pay what Anita bills, we have to match. So we have to reconcile that. We are reconciling it monthly, but it's all labor. It's all, I should say, manual labor. So we don't really have an electronic way to do that. which is what this goal was created from. So is to try to get an electronic process going and something that's more efficient. So we had to put that on hold a little bit. As Anita mentioned, we did a re-implementation of our electronic health record, and that was done in May of this year. And Joxel is the company we're working with, and they are finishing up other projects right now, so we haven't restarted to work with them on this initiative. But what we have done is I've met with finance, I've met with finance, and Doug, were you in there? I don't even remember. We all met to see if we could do something internally while we're waiting for Joxel to come on board with this initiative. So we just started that last week, actually, and we have some good bullet points on the table that we can act on to get the ball rolling and start improving some of the process of that. So, and we will bring Joxel in once they're done, but we just need to keep moving on it and not have it just sit there. So we're on target still. We're just still working on it. So.
And if I could add, the importance of the WIMCR reporting is not just that it's a report, it also brings in significant revenue to the department, because for comprehensive community services specifically, it's to make us whole. And so what that means is to cover the costs of all the folks who do the work, who you can't bill for. And so last year we brought in $1.8 million in WIMCR, and it's a very significant impact to our budget. And it's a very complex and probably hair-pulling process that the team has been working on. And so I can tell you, I always like to tell this story. I don't know why, because it's not a good one, but 7 years ago when I came here, we were not submitting a WIMCR report, which means we were leaving lots of money on the table. And so the team has been doing all of this work all of these years to just continually to do a quality and process improvement, because it is not an easy task, but it's very important.
Any questions?
No.
No? Okay, thank you.
Chris? Okay. All right, thank you, Lee. The next item is for Doug, the Behavioral Health Quarterly Report.
Hello, I am Doug Bryan, the Behavioral Health Division Manager. I'm reporting to you on 3 of my initiatives. The first one was improving the quality of services in the Behavioral Health Division. In doing that, we implemented onboarding checklists for the supervisors to ensure staff are trained in all the statutes, and where there's a formal policy forthcoming on that. As part of that process, I confirmed that all of the supervisors are using chart audits as a way to ensure that there are not mistakes made which relate directly back to billing practices that would either force us to pay money back or not allow us to bill for services. Some of the things that those onboarding checklists affords us is it assists with consistency across the board. So when the case managers are onboarded, they all hear the same thing on their onboarding process from the supervisor. It allows us to reduce mistakes in the work that they do, which is obviously important. And another thing it does is it holds staff accountable by being able to refer back to that checklist if there's any kind of performance issue that relates back to that we've checked off. Like, well, we did talk about this in your onboarding, and that's a really important piece of your job, and how that can relate to helping us support people to improve. Chart auditing is something that goes on by the supervisors do. They all have a slightly different process depending upon their team's job duties. It obviously heads off mistakes. We find a mistake in someone's chart. If the mistakes are more extensive, that will lead to a more extensive chart review. Perhaps the whole caseload for that staff person is reviewed. It also allows us to identify something that is maybe being billed out that shouldn't be, so we can quickly correct that problem. We might have to send some money back to Medicaid, which is appropriate to do if we found a mistake, and then correct that error. So it keeps us on top of that process, so we don't find ourselves down the road a year in looking at a whole bunch of errors that require a large payback. The second one is related to Anita's that she talked about, which was about maximizing our revenue. And what we've done in those meetings is looked at 2021, 22, and 23 in terms of our revenue. And Anita looks at that just based on what is posted into the system. So it's not parsed out by each team or even by clinician at this point, but it does show us the year-end billable and receivable dollars for reimbursement. The plan for this going forward is to continue to get quarterly reports from finance. We can identify trends rather than wait until the end of the year. And then at the end of the year, in the first quarter of the next year, we'll be able to look at the final outcome for that year and then just identify trends, look at areas for improvement. And by that time, we'll be able to drill down more to specific teams, what their reimbursement was, and eventually move to what kind of claims were rejected and why were they rejected and what did we miss, which all ties in with one of Anita's staff who does coding for us, because we want to maximize our dollars, especially for our prescribers who obviously have the highest reimbursement rates in the clinic. And so having someone in to make sure that we're not undercoding is really important, but it's also important not to overcode, because then that money has to go back. So those are all tied into these goals for revenue.
Supervisor
Okay,
Gales.
question. So
Yes.
if I'm looking at this right, is this increase BHD revenue by 10%? Q1,
Yes.
Q4 2024? Based upon what you just described, and yes, make sure it's accurate, but also not inaccurate, right? So you're not doing these and you're here. Is 10% aggressive?
Well, what's interesting is
Sorry, I'll finish a question.
Oh, go ahead. Sure, I'm sorry.
What I took out of the descriptor is relative to all funding streams. So part of my mind saying, well, are there other funding streams to Ms. Driscoll's comment about 7, 8 years ago, we missed a revenue stream. Well, are you implying that there are potentially other revenue streams, or is it just ensuring our processes are making sure that we're level and that we're not doing this?
Yes, it would be for all the known revenue streams. So I'm always wanting to make sure there's not another stream out there that we're not dipping into. So commercial insurance is a much lower metric for our services because community mental health typically doesn't serve that population. We're here for the underinsured. But on the occasion when we do have commercially insured people in the clinic for whatever reason, acuity, no other providers in their network, whatever it might be, we want to make sure that we are tapping into those dollars because we should be able to get reimbursed by commercial insurance providers. So our biggest revenue stream in terms of reimbursement would be Medicaid, Medicare, commercial insurance, and then private pay. So for people who have no coverage, they go through an ability to pay process, and as Anita mentioned, now we are actually collecting on those. We want to make sure that we don't leave that money on the table either. So we will work with people. Their ability to pay might be really low, which is a process they go through based on the federal poverty guidelines, but we still work with them on what kind of payment can you make for your services. So even if it's $5 a month, when you come in, can you pay $5? So we'll continue to collect that. So that's another revenue stream that I always want to make sure that we're not just writing that off and that we are collecting just like any other provider would do.
Excellent.
And I mean, for what it's worth, too, I did have some numbers here. We had a 16% increase in total revenue from 21 to 22, and from 22 to 23 it was 11%. So again, there's something else in that data that makes me want to go back and look and see where was 16 to 11. Was it numbers? Was it number of people? Was it a coding person? Did we catch an error? Did we have a payback? I mean, there's so many other variables to that, but that's the beginning of this process.
That's great.
And
that
to
you're
your
looking-
remark earlier about AI, I do have a training next week that the Behavioral Health Training Partnership Steering Committee is sponsoring, and there is a presentation about human services and using artificial intelligence and how it can be useful for county government and county mental health. So more to come. And the last goal I'm going to report on is The expansion of substance abuse services in Washington County, which was, of course, as you know, our plan to get an RFP out for a sober living facility. So we are on track for that. The final RFP is with Bill Kerr, for purchasing manager, to make sure that it's consistent with our practices and what we're asking for and what we're looking for is consistent with what it should be, and make sure it's written well. It's being reviewed and edited as needed, and we are on track to have that completed. Then the RFP is slated to go out later this year.
Nice.
Great. Any other questions? Thanks, Doug.
Yep, thank you.
You have back-to-back reports on the Children and Family Quarterly Report? Where is that, Coral? Okay.
I did just want to comment this. I guess this is what we get for canceling July's meeting.
Oh, well.
Hello again.
Hello.
I am here now to discuss the two initiatives out of the Children and Families Division. The first one was improving the quality and consistency of access to community services. You may remember that we had applied for a guided process through the Child Welfare Training Partnership that encompasses both child welfare programs and behavioral health, and streamlining those services together between those two types of programs, and that we were accepted for that program. The program lasts right now, it just started actually August, so it's August of 2024 through May of 2025. And the team consists of myself and Doug. The three supervisors are Sarah Whitty, Christy. So Sarah Whitty is the youth services supervisor. Christy is the outpatient clinic supervisor, and then Jen Wilkins is the ongoing CPS supervisor from my team. So there's 2 managers, 3 supervisors, and then 3 direct line staff. So this is quite a robust multidisciplinary team tackling this. We will have 4 in-person trainings up in Wausau. We will have multiple Teams or Zoom check-in meetings, and then of course we will have internal meetings regarding the work that we will be doing. When we met last week, we set some preliminary goals or direction for our process, which is really around strategies to improve internal communication and service coordination for families in multiple systems. I think that's an overarching theme that you've heard tonight, that we try to do that the best that we can. And really it's specific to helping clients, of course, which is our main function, but also to improving support to our staff who are working together with complex families. So again, that just started. We're about to get rolling the second week of September with our first in-person kickoff meeting up in Wausau with the training partnership and the other counties that are participating. So subsequent updates on this particular initiative will be kind of following the work that we are doing, myself and Doug and our teams are doing on this particular initiative. So stay tuned.
Yes, sounds exciting.
The second initiative is analyzing the structure and sustainability of family court services. We have finished really the research from the other counties and other family court services programs. Really looking at, I think we looked at 6 counties, which are similar in size and scope to Washington, of course. And our preliminary finding is that the Washington County model, which is having 2 social workers really in human services do these custody and placement studies, is not how most other programs are structured. And it seems that most of the other programs live really with the court. So the next step with this is to, by end of September, is to sort of compile all of the information that we have and start analyzing and assessing the information and present it obviously to Julie and start those initial conversations, as well as the Family Court Services co-director, who is actually Julie Mall, who is also the Family Court Commissioner. So that will be brought, I am sure that'll be brought before this committee once we have our information, we've assessed that, and then the 2 directors have had conversations. And then I really should have put a second goal under here because the next phase of this then is after we've assessed the information, then we need to be really discussing the sustainability, which will be throughout the end of 2024.
Any questions? All right. Thank you much for the update.
Thank you.
Next, we have Veterans Mental Health Update.
Yeah, so I just wanted to bring this to this committee's attention. As you may recall, we received a grant in the amount of $30,000 last October, and then subsequently we were made aware that we received another $150,000 from the Veterans Administration. Our original proposal with the $30,000 was we wanted to be able to start offering mental health services in our clinic to veterans in Washington County. Excuse me. Previously, the VA preferred to have vets come to the VA, and for us in Washington County, that's in Milwaukee, to receive services. But they have, in the last several years, and Kurt can talk much more eloquently about this if need be, but they have expanded their willingness to let community mental health facilities provide that service more locally. And so we applied for this funding, received this $30,000 with the intent of becoming a provider of the VA community care so that we could bill that insurance. And we anticipated that would take a lot longer than it did. And so we were going to use the money so that people could get free therapy and free psychiatry meetings. And so, but that didn't take very long. So that was a big win for us. And so we have been able to service individuals. Some of them, for whatever reason, we are paying for through the grant, but most of them were able to bill their insurance and provide that service to them. So it's a huge shift in the way that people receive services and where they can receive those services. So that was a big win initially for us. But then when we were sitting there with all of this money and maybe about 7 or 8 clients who we could bill their insurance, we started having conversations about, well, how can we get this information out to other vets in our community that don't necessarily come through our doors. So we started a contract with Epic Creative, which is here in West Bend, and they've been doing some very specific targeted ads through social media and other places. And you can see some of those ads that are in the packet. And so we just really wanted to share that with you. And so we're really excited about this new initiative. It's one of those things, it's kind of like, why weren't we able to do this all along? But got to wait till the right people change and the change happens. So we're working on a couple of other ideas. One that Epic is working on with us is creating coasters that we will be having some partners deliver to local bars, restaurants, and liquor stores. That'll have a QR code so that when people are sort of sitting in a place, they get that with their, drink or water or whatever. And so to get that information out, we thought that was a really unique idea. We're also in conversations with the Parks Department around some park passes and whether we could make that happen for vets, as well as, I gotta read my own notes here. And my computer's not scrolling down, but you can see in my notes some of the other initiatives that we're having. So I just wanted to make sure that you guys were aware of this, because the way that I understand that it works, if you're a vet, you're getting targeted the ads, but if you're not, maybe you aren't getting targeted. So we're really excited about this. And again, I think it's been a really neat collaborative between behavioral health and our Veteran Services Office. And exciting. This came straight from the staff, and their idea, and they're wanting to do something more and reach this population. So it's just really exciting.
And that it moves so quickly. That's awesome. Rare. Any questions?
Ms. Driscoll, a couple of questions and or comments. So I guess let's call it like satellite servicing, right? Versus going to some, centralized geographic place. So I applaud that. So whoever, if we helped influence that, great. If not, but we're recipients and we can serve our citizens even better. To that end, the 8 that you mentioned, just curious, are those residents of Washington County, and do you, or And the second question is, do you have to be a resident of Washington County to partake in the services that are being offered through the county?
Yeah, so to receive services from our community mental health center, you do have to be a resident of Washington County. Most of those referrals have come straight out of our Veteran Service Office.
So then we probably know how many veterans we do have in a county, and maybe with some of our intel about PTSD and how many active and how many returnees, and how do we, get the word out. Have we tapped into some of those? You talk about marketing through Epic. Presumably there's support groups that I know there are, formal and informal. So I'm assuming that we're tapping all of those as part of that marketing. But one thing that occurred to me is, so right now we're using grant dollars, right? So what happens if those grant dollars are exhausted? How do we continue if people become dependent? Not dependent isn't the word, but if they become comfortable with those services provided here, and then all of a sudden we can't provide them, 2 years or a year from now, are we thinking about that?
Yeah, so the way, again, the way that we set up this program was so that we could become a billable provider for community care. And most vets do have that insurance. But the way in which our Community Mental Health Center is set up is it is set up to service uninsured or underinsured. And so we would continue to be able to provide services for those individuals, and we would likely move them into like a sliding scale fee type of situation if they didn't have an insurance that we could bill. I think Doug alluded to the conversation around commercial insurance. We typically don't manage people who have commercial insurance because we're competing then with the private sector, and the need really is in Medicaid and uninsured. But this is one of those examples around making sure that we can that continuity of care, and that we can bill insurance so somebody can stay with us. And so those are all things that they're working out in the clinic process and in the sort of the flow of work around when somebody comes into the clinic, and how we continue to be able to service them regardless of their insurance status. But interestingly, that has been easier than we thought, and didn't cost very much money. It was just more, the labor of the staff that already are there. And so that's where we want to make sure that we're actually just getting this information out, because we have, a certain percentage of the population that interact very often with, the Veteran Services Office and other, groups in the community. But we also want to reach those people who don't connect with those, regularly with those type of support groups and things like that.
And sorry for my lack of knowledge on this. So you mentioned that client being a veteran. What about immediate family members? I mean, they we talked earlier today about families, the juveniles, and their family being part of a solution and care. So does the services you provide allow for, family to participate in treatment or therapy or discussion or whatever it may be?
Yes, I'm going to say, so all the therapy that we provide is individualized for that individual. And so if there's a family component to that, the therapist would involve them in it as a way that makes sense for their treatment. And also if their family member needed treatment themselves or services themselves, they could also come to our clinic and be a client with us.
Thank you.
Yep.
Any other questions, comments? All right, thank you very much. Great update. And our last agenda item is the 6-month financials for the out-of-home care, and inpatient hospitalization. Julie.
Yep. So for those who are maybe new to this committee, this is a report that we provide twice a year to just give you a sense of where we're trending and where we're at with what are the two biggest drivers of cost in our department. As you can see, our budget and our costs continue to increase year over year. Every year we we try to increase what we budget to be more aligned with what we're actually seeing or what we're spending. But we're also implementing strategies to decrease that deep end, services, which are hospitalizations and out-of-home care. As you heard about, FCT today is one of those interventions that we've implemented. Our co-responder unit is another big initiative that we've implemented. We have our own residential care facility here in Washington County, and we're working with them right now in a preliminary conversation about a redesign to really see if we can make sure we're meeting the needs of the community and the kids in the right way. I want to preface the conversation about this this report on that. Although every year we are overspent in our line item for both out-of-home care and inpatient hospitalization, our budget always comes in under budget, at least in the last 7 years. And we're projected to come in under budget this year as well. I will say what I know about many, many other counties is that is not necessarily the case. So I'm pretty proud of our team for all this work that we've been talking about with you today around, really making our budget and our finances a focal point to make sure that we can provide the right service, but that we're also doing it in a responsible way. As you can see, our out-of-home care cost, residential care is the highest driver of cost. And one of the reasons, or one data point for that, is out-of-state placements. We have a couple of kids who have some needs that could not be met here in Wisconsin, and we've had them placed out of state, and that is, a significant more cost than it is if they're in state. Also, as Coral discussed earlier, it's the length of stay. Some folks can be 12, 16, 18 months in a residential care facility. We've been working on a number of initiatives. I think last year our residential care budget line item was probably the worst it's ever been, and it was quite alarming. And so when we recognized that about a year ago, probably 6 months into 2023, we started really focusing on a number of initiatives around work process and supervisory, review of cases to make sure that kids weren't languishing in a placement in an inappropriate way, and to really push families and their care team to attempt community-based interventions before we place kids. We're never going to be able to not place kids in residential care. We're always going to have a need for that. But, making sure that it is the most appropriate level of care for individuals. And I think the work that team has done is evident in what we're trending in 2024. So I'm really very pleased. And I think some of these other things like FCT and the work that we're doing with Riverbend Place will further that. And really, we spent a lot of time talking about the dollars and cents of all this, but really it's about improved outcomes. And we think that, and we know that, kids who are staying in their community and can stay with their family and receive services, and that they're really going to have a better outcome than if they're placed elsewhere. Specifically if you move to our inpatient hospitalization, you see two line items there. One is inpatient that's hospitalizations. That's typically Winnebago. It could be other places like Waukesha has a hospital, number of different hospitals, but it's primarily Winnebago. And then the IMD is Trempealeau. And for those of you who are not in the committee, in the last couple of years, we've done a number of significant initiatives to reduce our Trempealeau placements. Doug's team did a lot of work to find appropriate community-based placements for those individuals, because they, again, were languishing in Trempealeau in a placement that really wasn't appropriate. The goal is always to have the lowest level of care that's appropriate for an individual, and institutionalization is only appropriate in very rare places for instances for a long period of time. So you'll see the IMD budget last year, what we had been typically budgeting and what we actually spent was almost nothing. And so we did reduce that budget in 2024, and I believe we have one placement there right now, so we'll have some cost, but not what we were seeing in the past. The other thing that's interesting to know about inpatient placement, especially at Winnebago, is if people have insurance, they do receive reimbursement for their stay. Winnebago does, and then they reimburse us. But it's always anywhere from 3 to 6 to 9 month lag. And then it just shows up on our invoice. So as an example, if we have $10,000 worth of cost in the month of August, but they received a payment from insurance in the amount of $8,000, we would only have a $2,000 payment due that month, even though that wasn't our cost. And the payments are from clients who were there months prior. So it's super complicated. And so that's where, while we can look at the number of placements we make every year, and look at, is that going up or is that going down? But we can't always control the dollar amount that's spent or not spent because the reimbursement is coming in a strange way. But I think the takeaway, again, for inpatient is, we're within target. We're not extremely projecting to be overspent. So I'm pleased with what I'm seeing so far this year. And I know the team is doing a lot of work around really trying to meet the needs of individuals in the right way, but also, not hospitalizing or institutionalizing people when it's not appropriate. Any questions?
Actually, you might have answered part of my question. So going back to the residential care centers, to your point about actuals being greater, with the exception of 2019, was approximately 50% more actual versus budget. And I look at 2024, we're estimating that it will be pretty much on budget. So you alluded to some changes that you were making based upon last year, almost double, right? 900 to 200 something, whatever, so, or over 100% increase. So you have a degree of confidence that the actuals in 2024 will be close to budget and not 50% more like we've seen historically?
Yes, that's correct. And I think to just describe it a little bit more clear, so we do have a new supervisor, and we've set some very specific expectations with that supervisor around regular meetings with staff around kids who are both placed in RCC, so the residential care center, and then kids who are potentially going to be placed or they're wanting to be placed. Sometimes residential care centers can be an easy answer for social workers and families. You have a child with very significant behaviors, as you discussed in the FCT presentation, and everybody's at their wits' end. And parents don't want the kid in their care. And these kids need treatment. And so, the residential care facility or center is appropriate when the treatment needs cannot be met in the community and the child's behaviors really need that intensive, more sort of institutional level of service. But the outcomes aren't always what we expect because the kid is getting all of that treatment and the family is nothing's changing in the family. So they go home and the family still remembers all the things that have been happening and they haven't done any work on themselves, right? I mean, kids don't just miraculously show up and have poor behavior. They're usually a product of their environment. So, and so that's where you're sort of seeing the disconnect. And so I think it's been a mind shift, a culture shift with the staff and the conversations, how they have conversations with families around trying other community-based interventions before we go to the level of placement. And I think that shift and really, sort of setting that really hard expectation with the supervisor and that team I think that has been the biggest impact.
Yeah, that's great. Which benefits everybody that you talked about earlier.
Right.
The child, the family. Okay. Thank you.
Yeah, you're welcome.
Anything else? All right. Well, thank you very much. Great presentations today. Our next meeting date will be